Today we will debate to embolize or to operate. That is the question. But I'm going to give you some history. Non-operative management of isolated splenic injury. It began in Toronto in the 1960s, and it basically began with pediatric patients. Today, non-operative management is the standard of care in both adults and children who are hemodynamically stable after blunt trauma. Hemodynamically stable. And anywhere from, it's been reported as low as 53%, as high as 95% of patients with blunt splenic injury meet currently accepted criteria for non-operative management. So why non-operative management? Why in the world are we doing this? We are surgeons after all. Well, we have better CT evaluation, so we can actually look inside the abdomen without having to cut the patient open. So that's why there was that's one of the reasons why there's progression over to non-operative management. We have better monitoring and resuscitation efforts, so we can put those patients in the ICU, monitor them very closely. If they have a problem, we know it, and we can take care of it. Many times, after the trauma patient came in way back in the day, you would do a DPL, or you would get the CT scan, and you would see blood. And then you would take the patient to the operating room and you'd find that the patient wasn't bleeding after all. They had already stopped bleeding. And then there's theoretical benefits. Some people think that you have decreased blood product usage with non-operative management. And some people talk about decreasing perioperative morbidity and mortality with non-operative management. And we're going to talk about that. And then, of course, the most feared complication related to splenectomy. OPSI, oh yes, OPSI. Overwhelming post-splenectomy infection. It's caused by encapsulated organisms, but the incidence is really poorly defined. We do know that children have a higher risk of it, and we also know that patients who have their spleens out for reasons other than trauma also have a higher risk of it, but we don't really know the exact numbers. There's never been a study to look at this. All right, so background. Splenic artery embolization. It was first used to treat hypersplenism in hematology patients. So patient would come in and they had this huge palpable spleen. So what they would do is they would shoot some coils down the splenic artery to cause it to infarct, to shrink, so that you could get the spleen out easier. Splenic artery embolization in the management of splenic trauma was first reported by Sclafani in 1981. Does anyone know who Sclafani was? Can you guess? He's a what? He's an interventional radiologist. That's exactly correct. He is not a surgeon. Splenic angioembolization has been advocated to increase the success rate of non-operative management in selected patients. And those patients are those that are hemodynamically stable with a contrast blush on CT. You can also embolize patients who have a pseudoaneurysm on CT. The problem is that there is concern that has been raised about the potential impact of angioembolization as an adjunct to non-operative management due to rebleeding, splenic rupture, abscess, septicemia, pneumonia. We really don't know about OPSI if it helps or not. Historically, the presence of a contrast blush on a CT scan has been an indication for operative intervention. Today, about half of the trauma centers advocate non-operative management with angioembolization, and the other half advocate splenectomy. I'm in the other half with splenectomy. This is the first study I want to talk about. This is by Hadley Smith and Walt Biffle when he was at Brown University in Rhode Island. And the purpose of this study was to review their experience with splenic embolization and to identify predictors of failure of embolization. This was a retrospective study that was done over a 5-year period. And basically, all patients that had blunt splenic injuries were undergoing splenic embolization were included. All of their admission CT scans were reread and graded according to the AAST spleen injury scale by a radiologist who is blinded to the clinical outcome. Okay? They have an institutional protocol that if you are hemodynamically stable with a splenic injury by CT scan, you'll undergo embolization if there's an arterial blush on CT. They also have a second group that if they didn't see a blush, but there are signs of ongoing bleeding attributed to the splenic injury, those patients will also get embolized. Their embolization techniques are coil versus particulate embolization and proximal versus distal embolization, and that was at the discretion of the interventional radiologist. This is just a diagram of their scheme. Results, they had 221 patients that were admitted with blunt splenic injuries. 25% of those patients went directly to the operating room for splenectomy. 124 of the remaining, or 75%, were managed expectantly. Of that 124, a fourth of them were taken to the angio suite for embolization. Their overall failure rate of non-operative management was 14%. The failure rate increased, though, with increasing injury grade for the overall group and for those managed without SAE. So, if you look at this diagram, you'll see non-op management. These are all comers, either embolized or not embolized. And you see that their total failure rate was 14%. And you can see that those patients that had grade 3, 4, and 5 injuries had higher rates of failure than the grades 1 and 2. If you look at the embolized group, they had an overall failure rate of 27%, and they were all of those patients occurred with grade 3, 4, and 5 injuries. So if you exclude grades 1 and 2 who had no failures, you had about a 40% failure rate for each group if you had a splenic injury that was worse than a grade 3. Of the 41 patients who failed embolization, 36% had moderate to large amounts of hemoperitoneum on CT. So overall, their failure rates, if they had gel foam embolization, they had a 50% failure rate. Coils, they had a 23% failure rate, so coils seems to be better than gel foam. Selective distal embolization failed in 33%. Main splenic artery failed in 22%, so main splenic artery failure rate was lower, which kind of defeats the purpose of doing splenic artery embolization, because the whole purpose is to preserve the spleen. If you coil the main splenic artery, then you're not getting the benefit of the spleen. I'll let you talk when you get to talk. You don't talk right now. It's my turn to talk. And 14 patients had evidence of pseudoaneurysm on angiography, of whom 29% failed. So the summary of this study: angiography appears to have good predictive value. Embolization was more likely to fail if active extravasation was seen on angiography before embolization. Before the embolization. So the patient went down to the angiography suite, they actually saw the blush, the patient was more likely to fail. If you combined active extravasation on angiography with a moderate or large hemoperitoneum, 71% of those patients failed SAE. So if you took them down to the angiography suite, you squirted them, let me back up. If you got a CT scan and you saw moderate to large hemoperitoneum, and then you took them to the angiography suite and saw active extravasation, 71% of those patients failed embolization. Second study I want to talk about is by Duchesne, who's out of the University of Mississippi, good old Southern boys. Basically, what they looked at is comparing the outcomes of embolization versus a cohort of patients who were treated with purely splenectomy. And basically, the way this turned out is that they did no embolizations, and then they had a transition point to where they were doing embolizations, and that's what they looked at. It was a 5-year retrospective study with blunt abdominal trauma. Isolated splenic injury with CT evidence of active extravasation were included in the study. Exclusions: if you were hemodynamically stable, you weren't included, and if you had to have emergent operative intervention for another injury. So, for example, if you had peritonitis because of a bowel injury, or you were bleeding because of your liver, you weren't included. So, 60 months, they had 682 blunt splenic injuries, 527 of whom were hemodynamically stable and met non-operative management. they had 154 patients who had contrast extravasation on CT scan. They broke those patients down. 30 months prior to embolization was the patients who were, quote, the pre-embolization era, 78 patients. 30 months after embolization was instituted, they had 76 patients in Group 2. Group 1 patients, they had operative management for their initial strategy, which was open splenectomy. They did no splenorrhaphies. Group 2, the second group, the management was initiated with angiography and proximal embolization with coils or gel foam. Basically, there's no difference in between the two groups. And there was no difference in the number of packed red cells transfused, no statistical significance, 5.1 for the first group. Yeah, the study's too small. 7.9 for the
Group 2 was the one that underwent embolization?
This is the group that underwent embolization. Mortality rate was not statistically significant, and length of stay was not statistically significantly different. But when they looked at the complications, they did find a few things. They had a higher incidence of ARDS in Group 2, 5% versus 22%. Granted, it's a small study, but that's the only studies we have, really. There's a higher rate of septic complications in Group 2. Splenic abscess, septicemia, pneumonia wasn't statistically significant, but it was trending towards that direction. So if you took the higher grade injuries, those patients who are in grades 3, 4, and 5, again, small numbers, 66 and 50 there, ARDS difference was significantly different. Sepsis mortality rate was not different. The subgroup analysis of Group 2, 29% failed non-operative management after undergoing proximal embolization. And the failure of non-operative management strategy is directly related to the organ injury grades. So grades 3, 4, and 5 had higher failure rates. Predictors of failure of non-operative management were those patients who had higher ISS, higher AAST splenic injury grades, and who had lower presenting systolic blood pressures, and this is represented right here graphically or chartly. If you looked at the patients, when they compared the outcomes of septic complications between successful and failed embolization, if you were successfully embolized, 54 of those patients, your sepsis rate was no different. Again, small numbers, I know. But your ARDS was higher in your failed group. Your red cells were higher in the failed group. Hospital length of stay was higher, and mortality was also higher. The summary for this study is that in low-grade blunt splenic trauma without active contrast extravasation, embolization is no better than operative management in terms of feasibility, safety, or effectiveness. However, in high-grade injuries with contrast extravasation, there are equivalent mortality rates and length of stay between operative management and non-operative management with proximal SAE, but there is a higher mortality rate in patients who failed non-operative management. Does that make sense to everyone? So if you embolize somebody and they fail, they're going to die, or they have a higher chance of dying. Well, it is what it is. And they also have higher rates of sepsis and ARDS. Third study I want to talk about, this was done by a group out of Boston University. And what they were looking at is short-term outcomes associated with immediate splenectomy versus splenic preservation. This is a retrospective study, as all of these studies are retrospective studies at a level 1 institution, namely Brown University. And they compare complication rates related to the treatment of the splenic injury in terms of immediate splenectomy, non-operative management, those patients who had splenic artery embolizations, and those patients who had splenorrhaphy. Over 2.5 years, they had 170 patients with splenic injuries. 145 were due to blunt, 25 were due to penetrating. And here are the results. For the blunt trauma patients, they had 4 out of 46 patients, 4 complications. They had 3 pancreatic leaks and 1 gastrocutaneous fistula for a complication rate of 8.7%. So what does that mean? That means, Dr. Lopez, when you're taking someone's spleen out, you need to be damn careful that you don't get into the pancreas. Okay? All right. So there you go. If they did expectant management, meaning just plain non-operative management without embolization, they had a 12.5% complication rate. And all of those complications were due to continued bleeding. If you embolize, they only had 11. Small numbers, I know. They only had 11, but they had a 27.2% complication rate. They were all due to bleeding, and all of those patients ultimately had to go have their spleens taken out. And then if you did a splenophraphy, you had a complication rate that was similar to expectant management, 12.5%, and it was due to continued bleeding. So this is their results represented graphically. It is graphically this time, not chartly. And the summary for this study is that the lowest percent complication was observed in the operative group, 8.7%. All complications in this group were related to fistula and leak. The highest percentage complications was observed in the embolization group. They are all related to continued bleeding. None of these patients had become hemodynamically unstable after their embolization, but they all required splenectomy. So you had to go to the operating room after all. The last study I want to talk about is complications associated with embolization in the treatment of blunt splenic injury. This is out of Taiwan, actually. 152 consecutive patients over a 2.5-year period. They are managed by an established algorithm that says if you have an isolated splenic injury, yes, and then you had contrast extravasation or a large hemiperitoneum, yes, and stable vital signs, then you went to angioembolization. If you were unstable, you went to the operating room, and if you were stable, you went to the non-operative management arm of their flow sheet. Hemodynamically stable patients that exhibited the following CT findings were candidates for embolization, contrast blush or pseudoaneurysm, or large hemiperitoneum. I just want to make a few definitions for you, or define a few things for you. They define major complications as direct adverse effects rising from the embolization that were potentially fatal or resulted in disability. Minor complications were adverse effects that were not critical or life-threatening. These patients were evaluated by abdominal CT scans and ultrasound for 6 months follow-up after discharge. They had 79 patients in the non-operative group. 58 patients had non-operative management alone. 21 patients had non-operative management with embolization. The mean ISS was 26. The mean splenic injury score was 3.4. Their splenic salvage rate was 76.2%. What you'll know is that they had 7 major complications, something that was potentially life-threatening, in 21 patients who were managed by splenic angioembolization. They had 4 patients who bled and required splenectomy. So 67% of this number required splenectomy. Of these complications required splenectomy. They had 1 patient that had a total or near total splenic infarct, and then 1 patient who just had splenic atrophy. The minor complications, fever, pleural effusion, and partial splenic infarctions after embolization. 27 minor complications in 13 of 21 patients, so 61.9% of patients had a minor complication. So 26 had major, 61 had minor. Their summary, or the summary of this study, is that splenic preservation and salvage are associated with increased complication rates, and they require you to frequently assess the patient to identify those who need additional work. So the bottom line for us pro-operative people: active extravasation of IV contrast from the splenic parenchyma on CT, it's an ominous sign of vascular injury. It's a predictor of non-operative management failure, particularly if you have a moderate to large amount of hemoperitoneum. So if you see contrast extravasation and a large amount of blood on CT scan, 71% of those patients are going to fail embolization. A splenic salvage with embolization is no better than operative intervention in low-grade injuries. Mortality is the same, complications are the same, but it does have an increased morbidity and mortality in high-grade injuries. Active contrast extravasation on CT scans for grades 3 through 5 injuries should have splenectomy performed because there's a higher complication rate, there's a higher mortality rate for embolization. And if the patient fails non-operative management with embolization, which again, depending on what study you're looking at, 25 to 40% of those patients they will end up with a splenectomy anyway. That's all I got. Your go.
Hold on, let me give her.
Good afternoon, everyone. I'm very delighted to talk about this topic. And before I start, I have the privilege of having my opponent go first. So I want you to remember very important points. Most of the studies that my opponent showed were based on 20-something, 40-something patients. I'm going to show you data based on large number of patients, which is how we should make decisions, not based on anecdotal learning curve data, but on validated large study experience and data. So bear that in mind. So the title says to operate or not to operate. The title can also be to embolize or not to embolize. I kind of left to operate or not to operate as well, just to get you guys to understand where we came from. Before I start, I want to mention something about status quo. I found this quote and I absolutely love it and kind of governs most of the things I do. Insanity is repeating the same actions over and over again and again and expecting different results. So if you want different results, you gotta do something different. So what were we doing before? What can we do differently? Actually, Bill Roth, you all are familiar with, was the first person to report that the spontaneous healing of ruptured spleen is possible because he found it incidentally in an autopsy. Berger, who was also a very notable surgeon at that time, said that non-operative management resulted in 90 to 100% mortality, which suggests that some surgeons at that time also were maybe experimenting with non-operative management in the 19th century. So this notable observation by Birot was trumped by Bailey, who quoted Tumble. Tumble is a very popular pathologist of their time that said that he's never seen any healed spleen during autopsy. And he made this statement: nature fails so frequently that we must assume that surgical aid is always needed, quote unquote, by a very reputable surgeon. Wrong, as we know now. Later on, other reports showed autopsy evidence of spontaneous healing of the spleen and attracted little attention because why? It wasn't part of the status quo at that time. It wasn't popular belief at that time. And it's remarkable that as recently as the 1960s, Shirky reported that spontaneous healing of the ruptured spleen, if it occurred at all, is rare. What do we know now? That he's also wrong about that. In 1902, Berger found 14 patients who were treated with suture of the splenic wounds. They did better than the ones that had splenectomy. 1911, Coker says, injuries of the spleen demand excision of the gland. No evil effects follows its removal, while the danger of hemorrhage is effectively stopped. So, famous surgeon, 1911 says, all spleen must be removed. So all surgeons, so what do we know about this statement now? Wrong. Okay? Dreska in 1930, 1945, the smaller, not very well-known surgeons publishing in other journals were mentioning about how they were treating patients successfully, non-operatively. These reports were largely ignored. In 1962, Christo performed successful partial splenectomy in 8 patients, reported that all these reports were ignored. It wasn't part of the status quo. We ended up learning from children. There was a change in the treatment of adults because multiple, as my proponent largely commented on, I won't spend much time on this, but in the 60s, there were efforts to preserve the spleen in children. And multiple reports, as you can see from those citations, actually got up to 98% in some children by conservative management. So we learned from children, and fortunately, in the past 30 years, there have been significant advances in the management of traumatic splenic injuries. And non-operative management, despite what the famous Coker said, despite what all the famous surgeons who believed it was not possible said, is now the standard of care. So understanding where we came from is extremely important. We are all familiar with scaling for splenic injury. It's correct that the CT scan is the one thing that has helped us recently, because now we can grade the injuries. We can tell which ones may require non-operative management versus operation based on this scaling that the AAST has provided for us, American Association for the Surgery of Trauma. So this guide helps us to select patients. All of us are familiar with this gradation. I won't spend time on it. This is important, though, because the Eastern Association went back to now look when the trend started changing from going from children to adults. The argument we're having now about embolization was occurring between operative versus non-operative management. So the Eastern Association decided to go back and look and do a multi-institutional study to find out what is actually the trend, what is actually the truth about operative versus non-operative management, who can be salvaged and who cannot. And they looked at a total of 1,488 patients. Notice 1,488 patients greater than 15 years of age. They looked at 27 trauma settings. Notice multi-center study. And they found that 61.5% were managed non-operatively. That's a change as opposed to when it was 100%. A definite change. Why did they choose 1997? Look at the trend. If you look at this diagram, you can see they first of all looked at 1993 to 1997, and they noted that direct to operating room was significantly lower. You can see it went from 52% in 1993 to 39% in 1997. And again, I'm talking about thousands of patients. And also notice the last column, the change in failed non-operative management. It got up to 50% in 1993, and the highest was 24% in 1997. Again, I'm talking about thousands of patients. I'm talking about multiple centers. So this is a change, which is against what was believed in the past. So based on that study, as suspected, the AAST grading helps us, of course, because you can see very clearly that the initial management of blunt splenic injury by grade was different. So the ones in, these are the ones that were managed non-operatively initially, which decreased as the grade increased, and of course the ones that were managed straight to the operating room increased. So in the 1990s, when East was looking at this study, 1997, 94.9% of patients for grade 5 were going straight to the operating room, no conversation. Should this change? So the question is, can we change this? This is the focus of our talk today, actually. Can we get less than 94% to 97% to go to the operating room? And I'll go into show you data to show that we can. Again, failure of non-operative management, of course, based on that Eastern study of, again, 1,400 and something patients, is increased with non-operative management, which is this areas, 33% and 70-something%. Anyway, so again, how can we make this number better? And that's what we're talking about. How can we make this better? We're doing good here. We're okay. At least we need to focus on where we can do better. So let's talk about home a little bit. We're still looking at this data, so we don't have all the information. But here at UCSD, they kindly provided this table to me. And you can see that we have gone from 40% to even down to less than 20% patients that non-operative management versus operation. So there's a very clear trend as the data from the East trial showed. And of these, you can see that 52% non-operative management was in 1998, now to 78%. So we made a change within this 10-year period, and we have not seen an increase in failure rate while making that change. So this is our UCSD protocol, which we're all familiar with. And of course, as my proponent very clearly summarized, that hemodynamic status is one of the most important predictors of who goes to the OR and who doesn't. Our protocol says if there's contrast extravasation for splenic injury, they go to the operating room for repair or for splenectomy. So again, however, if you notice up here, the people with liver and kidney can have the option of angioembolization. How come we can't do that for spleen? Again, that's what we're going to discuss about. It's if we have been able to get up to that, what is the problem with spleen? And let's look at the data. So over the past decade, angiography with transcatheter splenic artery embolization has emerged as an alternative, and results as high as 97% has been reported. Success rates of more than 80% in multiple studies. This is a very good review article, which instead of talking about one center with 20-something patients versus 40 patients, I highly recommend to look at this article, which talks about all the articles that's been published on this topic up to 2008. I thought it was a very good review article. So I kind of focused most of my review using that article to look at all the other embolization in spleen in trauma data. In any case, this is just an example of selective splenic angiogram where you see what looks like a blush here, and then after the embolization, you see areas of infarct where there's no more evidence of a blush. You see there's no more contrast extravasation. So that's one of a sample of a patient. Proximal splenic artery embolization promotes hemostasis. It reduces intrasplenic blood pressure, facilitates clot formation and the healing of the spleen. But the splenic perfusion is likely maintained through a collateral artery network. So coiling the main splenic artery does not exclude subsequent perfusion of the spleen. That is a common misunderstanding. Studies have shown, even in dogs, that splenic perfusion is likely maintained through a collateral artery network. So this proximal splenic artery embolization catheter is selected, and the coil is occludes blood flow at least beyond the origin of the dorsal pancreatic artery. So although it's proximal, like I mentioned, the spleen can still be perfused by collaterals. While the super selective, which would make more sense to use that it advanced close to the site of the vascular injury for coil embolization or gel foam. So you coil with the proximal, you do coil or gel foam with the super selective. There's only one problem. Although it makes logical sense to choose super selective, however, after distal embolization, these patients may fail. So some of the reports you may be seeing on failed splenic embolization may be due to the technique, as I will show later, because with distal embolization, they might miss some areas that may have undergone vasospasm at the time of the embolization, and those areas may later on bleed. Areas of pseudoaneurysm may not be identified, which is why some are advocating, some who are more experienced in performing this technique, recommend doing the proximal coil embolization in order to have a better result. Another thing is that with distal embolization, surprisingly, you actually see more infarcts. A study have shown that on CT findings. Killen and colleagues showed that by CT, after imaging these patients, after selective, they tend to get more splenic infarcts. Again, like I mentioned, with proximal coil, there seems to be collaterals that eventually perfuse the spleen. So what I'm going to show you is all the data, at least till that publication in 2008, that has reported on splenic embolization. Although Dr. Sclafani from State University of New York is an interventional radiologist, he first reported this idea in 1981. But he, in 1995, reported on about 170-something patients from their institution, of which 60 underwent embolization. He did proximal, distal, or both. And he had overall success of non-operative management was amazing, 97%. I mean, you can tell that these people do this often because they had all their patients with grade 3 or more injury undergo angiography. That may not necessarily be the standard of care now because now CT scans are better. However, you can at least speculate that the fact that they were able to do so many, they became so good at it that they had better results. And since then, there has been other reports in 1996. These are fewer patients, so I will not focus on the patients that are 15, 26, 40, 35, but most of them showed very good success rate. Even the ones that did not have good success rates were due to technical failure, which they honestly acknowledged. But notice that these are smaller numbers. Let's go ahead and focus on things that can change our practice. I want to focus on this study on top, which is Hen and colleagues. This was organized by the Western Trauma Association, which looked at multi-center study from 4 institutions, from Brown University, from shock trauma in Maryland, also San Francisco General Hospital, and from Illinois. This is a very good study because now we're talking about patients in the hundreds, not in 20s. So, and it's multi-center, which is more reliable because we can make good conclusions from those. And in that case, they showed, I'm going to talk more about that study. So I will move along, but very quickly, I just want to mention that there were other studies too. This is a follow-up study from shock trauma in 2005 published. There are other smaller studies that showed reasonable success rate. However, we're going to talk more about the Western trauma surgery. So the Western study was a retrospective chart review, patients from 1997 to 2002, 4 separate level 1 trauma centers, like I mentioned. A total of 140 patients were reviewed. The splenic salvage rate was 87%, and which decreased with increasing injury grade. However, over 80% of splenic injury grades 4 and 5 were successfully managed non-operatively. So this is an improvement. This is a big change compared to the few studies that are showing that most of their grades 4 and 5 failed. Those studies are due to low number and inadequate exposure to the technique. That's my impression of those studies. So going further to explain this study, you can see that the outcome based on the AAST injury grade for grade 1, this is not very important because there was only 1% of the patients that was in grade 1. None of them only one patient had splenic embolization, and there was no splenic salvage in that. However, notice that patients with grade 4 or 5, a whopping 83% were able to be salvaged by splenic embolization. Although in the past, we used to believe that everybody with 4 or 5 should go to the operating room. This includes patients with extravasation. This includes patients with pseudoaneurysm. This includes patients with arterial venous fistula. The one thing that they did find is that the patients with arterial venous fistula had higher failure rate. What about the complications? We can't ignore that. Yes, there is a good amount of complications in patients that undergo splenic embolization, but I want you to pay attention to one very important thing that my opponent also pointed out. Most of the complications we're talking about is on hemorrhage. So the ones that fail and have to go to operating room most likely will have their complication to be hemorrhage. It's kind of unfair to compare complication in a patient who has already had the spleen out versus hemorrhage in the patient who has not had the spleen out. However, if you focus on that complication only, then the question is, how does that affect eventual outcome? In this particular large study patients, it did not increase mortality. It did not increase. Some of the patients actually could undergo repeat splenic embolization. It did not increase mortality at all. There are other complications that are of note, but none of them led to the point where you can say that splenic embolization needs to be abandoned. So this is the slide. If you don't remember everything else that I say today, please remember this slide. Now, remember the East slide that I talked to you about, the East study in the 1990s? I want to show you guys progress. In the 1990s, the E study was telling us that the salvage rate for grade 4 and grade 5 by non-operative management was 25% and 66%, and for grade 3 was only 80%. Grade 1 and 2 were doing okay. I don't think that's where the issue really is. It's grade 3 to 5. Look at the difference. This is less than a decade time, and the difference here is that splenic embolization was used, and you have improved salvage rate from 25% to 83%. That's improvement, and all of them were statistically significant from grade 3 to 5. Again, I'm talking about multi-center study with more than 100 patients. This is actually the study I will conclude with. I think this was a good study because this study looked at, again, hundreds of patients, although it was a single center study. Retrospective, this was actually from Case Western. They looked at 7-year periods, 1991 to 1998, which fits the East study when the comparison was operative versus non-operative, versus 1998 to 2005, where the comparison is what's happening with splenic embolization. And they had 403 patients from 1998 to 2005 compared to 222. They had, of course, the case match, and there were no, the only significant difference between this group of the first cohort and the later cohort is that the injury severity score increased from 1998 to 2005. So they had even sicker patients. Despite having sicker patients, they did have an increased frequency of arterial embolization from 2.7% to 22.6%, as would be expected. That was statistically significant. The success of non-operative management increased in this single institution from 77% to 96%. That was statistically significant. The splenic salvage rate for all patients improved from 57% to 88%. That was statistically significant. This is what I call progress. In this cohort of patients in the hundreds, there was no difference in hospital mortality. In fact, it decreased from 12% to 6%, despite higher injury severity score. This is telling me that the institutions that perform this procedure more and reporting higher number of patients have better outcome. So this is the initial treatment and outcomes. They went from the initial cohorts that 86% went immediately to operating room. That was reduced to 59%. Immediate angiography, nobody went, 56 went this time, 13.9%. Non-operative treatment improved 61% to 85%. Splenic salvage improved 56% to 88%. Again, look at the numbers, 222, 403. Deaths, 11.7%, 5.5%, statistically significant to be better in the later cohort. Now, you can say there are other things that contributed to this better result, but if more patients were dying due to more splenic embolization, you would not have seen this improvement. Duration of hospital stay, which I found really interesting, which could be also be a bias of time. However, it's also interesting to note that hospital stay was getting better. This could be a bias of time. I understand that. However, if splenic embolization was leading to worse outcome in these patients, you wouldn't have seen these good results. Again, we're talking about hundreds of patients. So this is the breakdown of their patients, which is basically what I've already summarized, whereby more patients in the later cohorts were going into angiography. And if you break down the outcome of the patients by grade, you will see that for the initial cohort where there was no embolization compared to the present cohort, the non-operative management success rate, just like we saw in the Western trauma cohort, was better in the present cohort just because they added splenic embolization. And you can see the salvage rate is better, the splenic salvage rate. Mortality, again, is not worse, and duration of hospital stay, like I mentioned, is not worse. This is only looking at patients with initial operative management. The previous data I showed was for all patients. So in summary, this is what was proposed by, I have to be grateful to Dr. Lacklin, whose literature review was an aid in my literature review. He published this in 2008. After looking at all the literature, including the ones that were talking about failure because mostly they had lower patients, I still think, he proposed this algorithm, which is something to consider. Modify according to institution, but a patient with a splenic injury with grade 3 to 5, active extravasation, pseudoaneurysm or AV fistula can be considered for angiography and embolization. That's after we've made the criteria of hemodynamic stability. If the patient is stable, they can be embolized. If they are unstable, of course, they go to laparotomy. So that clinical status assessment is what definitely helps. If the embolization is successful, the patient can be observed. And if he fails, they can either consider repeat embolization or go to the operating room. I also want to emphasize that none of the data that came from my opponent showed 100% failure rate. Yes, so there is something to this. It reminds me of things like laparoscopic cholecystectomy. When it first came, there was a very high complication rate comparatively because of learning curve. What I see here is a learning curve issue and volume issue. I feel that we as trauma surgeons, instead of pushing this aside, should actually consider training ourselves to do this ourselves, that if we're not successful, we can then take out the spleen. Because we are more equipped to know what to go for. We know how to do splenic artery embolization. We are able to convert immediately and make the operating room not just for that option. I mean, I think that's what vascular surgeons have done. We can do this. We don't have to push it aside and say we have to take out all the spleen. We have to see the future come in here and move in. Anyway, in conclusion, transcatheter splenic artery embolization has a major role in the management of traumatic splenic injuries. Its addition to non-operative management has been clearly shown in hundreds of patients to be feasible, safe, effective, increasing rates of splenic salvage. Embolization is particularly beneficial in injuries of higher grade, which previously everybody required laparotomy. I showed you that diagram that I wanted you to remember, the difference between the East data in the 1990s versus the Western Trauma Society data in the 2000s. Just so you know, this is not an East Coast, West Coast thing. This was more of multiple institutions and the society that was sponsoring it. In any case, clinical and CT-based criteria can be used effectively to triage patients between simple observation, angioembolization, and surgery. However, the success is based on good teamwork. The surgeons must communicate with radiologists as well as judicious selection. Of course, if there's any clinical compromise, you will have to reassess. But if there's good communication between surgeon and radiologist, this can happen. And institutes that have it happen more often, like Dr. Sclafani and colleagues, are showing outstanding results because everything is merged. I personally do propose that we, as trauma surgeons, look into being able to do this ourselves and take out the spleen when we have to, even when the embolization fails. I think that's what the future is. So in conclusion, beware of status quo. This is what Plato says. Perhaps if we go forward in the search, we may stumble upon the thing we are looking for. But if we stay where we are, which is take out every spleen we come across, then nothing will come to light. And only a dash flesh goes with the flow. I read about the history of, if you watch little fish in a small lake, and you watch them, if the lake is going downstream into the Great Lake, you watch the little fish, they actually try to swim upstream. It makes no sense because they're swimming against the current. So it will be easier for them to just go with the flow and get down to the Great Lake. But actually, as they are swimming against the current, that lake, the small lake, is gradually taking them to the Great Lake. The advantage of them swimming against the current is that by the time they get to the Great Lake, they are stronger. They can face any controversy. So although Coker said that spleens will always be removed, we know today that we can be selective about it. Thank you for your attention.
Okay, I wish
more so from non-operative management than getting their spleen out. I think the literature is well saturated with those studies, and I think by the way we practice here, the way most people practice in the United States, I think that's just very well defined. As far as embolization for management of grades 3, 4, and 5 patients. Just because we can do it doesn't necessarily mean we should do it. With patients who have failure rates upwards of 40%, I know what your studies show, or the few studies that you showed, but when you have failure rates upwards of 40%, those patients potentially have increased mortality, definitely increased morbidity. There is no reason to risk their life by dilly-dallying around in the first place. So the first point I would like to talk about is the Peitzman study, which actually had no mention of embolization in it. And I know you were just using it as a way to say that, yes, we are going into the non-operative management goal. Well, I accept that, and yes, I agree with that completely. You were looking at the UCSD protocol, and you actually made the comment why we embolize liver, we embolize kidney, why do we not embolize the spleen? Well, you can't live without your liver, so you can't just take the liver out. If you take out the kidneys, you go on dialysis. If you take out the spleen, you need an immunization. That's it. That's why we can take out the spleen. I'm not so sure about your comment on collateral arteries and perfusion of the spleen. I don't know that if you sacrifice the splenic artery, that your collaterals will actually give you sufficient immunofunction. I mean, it's been shown that way back when we used to take the spleen, crush it up, throw it in the abdomen, and those little pieces of spleen would grow, but there was no immune function to them. So I don't know really what the science is on as far as using or thinking that the collaterals will preserve the splenic function. It's kind of funny. The biggest talk that the biggest paper that you talked about was the Hahn study in 2004. Well, Biffle was part of that study, and he's the one that was my number one article that I used is his follow-up to that article. It says, maybe we've gone too far, and I think we have. I mean, I think that not everyone is a candidate for this, and I think that it's overused in some centers. 83% failure rate is still, 83% success rate is good, but you also have a 17% failure rate where that patient will go to the operating room, may develop ARDS, may need more blood products, may have increased septic complications. It's easier just to take it out and be done with it than futzing around with embolization. With all due respect, Dr. Sclafani is an expert. He's been doing it for 37 years, and he's. I would expect him to have a 98% or 97% success rate. You take some of the, I've seen it done here once, and we are 0 for 1. Okay? I have never seen it done at any other institution that I've been at, so I don't have any other experience with that. So, in regards to your mortality rates on your last study, you showed that the operative management had higher mortality rates. Well, that's from a prior period of critical care management. Those patients could have had higher mortality rates because of higher blood product use. Could have been a higher mortality rate related to ARDS, ALI. We don't know. So that's all I got for you. I'm still saying take the spleen out.
Well, let's 5-minute response.
But the reason why in my presentation I wanted us to really recognize where we came from when we believed that every spleen must be taken out. I see the history repeating itself. That's what I'm trying to emphasize. That as much as we believed that we must operate on all spleen because the problem is only immunization, well, we should not discount that the patient is undergoing surgery as well, with this possible attentive morbidity and mortality associated with just operative intervention. So that is one part. If we truly believe that the spleen is not that useful, the fact that we just only have to immunize, then let's go back to the statements made by Coker in 1911 and continue to take out all spleens. Then let's go back to what Hamilton Bailey said that says that we always need surgery. But that's not the case. So if we have accepted that, yes, there are some that can be salvaged and should be salvaged, it's reasonable to ask the question, can we salvage more? And that's the point I'm trying to make. Understandably, yes, the liver and the kidney are different. Yes, we want to preserve them for other reasons. But the same reasons that we are salvaging some spleens is the same reasons we should think about salvaging more if at all possible. So another thing that you mentioned about mortality rates are higher related to other factors. I would agree with that, that is possible. However, if the assumption, remember we're looking at only splenic artery injury patients in those cohorts, the study that I showed from Case Western. And the reason why I did not focus on patients with 20-something cases is because I think for us to accurately review the literature, we have to look at the big picture. We have to look at multi-center experience. We have to look at people that are doing it more and doing it better. So based on that, I think the study from Case Western is showing us, although it might be related to better ICU care, however, if those patients that underwent splenic artery embolization had higher mortality and higher morbidity, that should have reflected even more so and maybe made the result equal, but it did not. That's first of all. And second of all, the fact that, again, we're talking about institutes that are seeing more than 200 patients reporting better outcome is noteworthy. Sclafani and Collis, if they can do it well, then that tells us that what is the issue is the technique and the ability of the radiologist and not necessarily the success rate of the procedure. Because if you take our institution, for example, since we've been fellows here, we've done only one. We had a 100% failure rate. We cannot use anecdotal single reports to make a decision about selecting patients. So I may not necessarily catch all the other points. Oh, in terms of perfusion of the spleen, I think that's a very good point. The literature does not know and has not clearly shown that the preserved spleen after main artery embolization is necessarily an anatomically present spleen versus immunologically fully active spleen. That area does require further investigation. I will have to agree with you on that point. However, if a patient can avoid surgery, I think is worth the effort. I personally know that also, using the example of laparoscopic cholecystectomy again, if we don't, as trauma surgeons, get into this, the patients will drive the force that will allow them to have an option where they will not have to have a big incision and surgery. It has happened in cardiac surgery whereby stents, patients start preferring it. It has happened in general surgery where laparoscopic cholecystectomy was selected by the patient. So we also cannot ignore the fact that patients might selectively prefer to have embolization as opposed to having a big operation. I think those are the things I have. I agree with most of the points you brought out, but I still believe, like looking at large center studies and multiple patients, the potential for this to progressively lead to better salvage is still there. Thank you.
Good job. Fantastic.